Okay, hi everybody. So welcome to the last Grand Rounds of 2016. We'll be picking up again the first week in January with on Thursdays with Dr. Bruce Ransom, giving the first talk on MPTP story and movement disorders. That should be really interesting. Today we have a tag team talk with Stephen White and Melissa Barker-Haliski, who I've gotten to know this last year through our mutual research interests, and they have. I'm going to I'll say just a word or two about Stephen, and then he can talk a little more about Melissa. Stephen is a professor and chair in the Department of Pharmacy here at the University of Washington. He's been here now just under a year. And prior to that, he was at the University of Utah for 30 years as the professor and director of the Antiepileptic drug development program there. He has a number of research interests, but particularly on antiepileptic drug models and also the role of genetics in modulating response to antiepileptic drugs. Today's talk is going to be on modeling human antiepileptic drug adherence and treatment outcomes in preclinical epilepsy models. And I'm also need to tell you, please fill out the evaluation forms that are at the back of the room. We're trying to make a push to do that for all our Grand Round speakers. So thanks very much.
Thanks, John. It's a privilege to be here this afternoon and kind of share with you some of the activities that we're trying to establish here at the University of Washington in translational epilepsy research. And I'll introduce you to one of my patients in a moment, but the long and short of it is they have long, scaly tails, red beady eyes, and walk on all fours. But we'll tell you how they participate in a number of studies that we've done at Utah, but also bringing here. We're going to do this, as John mentioned, in a tag team. I'm going to talk initially about the adherence model that a PharmD PhD student of mine has been working on for the last couple of years, and he's finishing up his PhD component at Utah, and hopefully that'll be done in about a year. So let's see here. I probably don't have to tell this audience much about epilepsy. Looks like one of the figures here disappeared in the translation. But as you know, it's a neurological disorder that affects about 1% of the population. 65 million patients or people worldwide with epilepsy. And a staggering fact that recently released, 1 out of 26 Americans will be diagnosed with epilepsy at some point in their lifetime. And there's growing recognition that epilepsy is also associated with death, either through SUDEP, sudden unexplained death in epilepsy, or the result of a patient who may actually have a bout of status epilepticus. Importantly, and part of what we were striving to do at Utah and continue to strive to do here is that 25 to 30% of patients with epilepsy remain refractory to the existing therapies that are currently available to treat them. And as you can well imagine, the overall economic burden to the patient and the caregiver and society at large is significant, thought to reflect several $billion a year. And so clearly there's an unmet need for new therapies, and as has been in the past and continues to be today, animal models are used for identification of drugs that might be useful for the treatment of symptomatic epilepsy. And again, this is a CF1 mouse who is used very frequently in drug discovery studies, and the hope is that the data coming out of those mouse models, the acute evoked seizure models and chronic corneal kindling models or hippocampal or amygdala kindle models will lead to sufficient data to support an IND that will lead to ultimately testing in the patient population, and some $10 billion and 10 years later, that drug may show up on the pharmacy shelf and available to you and your patients for the treatment of their seizures. This process has been very successful over the last 40 years, and this just shows the exponential growth, if you will, in the number of drugs that have come on the market since the early 30s, beginning, well, first with phenobarbital back in 1912, but prior to that, bromide was used, and I'm sure many of you know that history. And then phenytoin was first tested in the CAT, maximal electroshock seizure test, by Merritt and Putnam in 1937, and 1 year later, phenytoin is available for the treatment of patients. So 1 year development program, that won't happen again. Although I have to say, cannabidiol has taken a very rapid development track as well, and that's been driven by a number of different factors. But the latest drug to come onto the market is brivaracetam. It's a very strong, potent cousin to levetiracetam, and all of these drugs have, since 1993, have come about in a large part, I think, through the initiative of the NINDS in trying to spur the development and discovery of new therapies. So all of these drugs available for the treatment, are there still treatment gaps? I think the answer to that is yes. And you see patients probably every day that need better therapies for their epilepsy. This is just one of many representative studies that show, regardless of the seizure type or the diagnosis, all localization-related epilepsies, cryptogenic epilepsies, or symptomatic epilepsies, it's about 35 to 40% of the patients are considered to be uncontrolled. Moreover, seizure control, when it does occur in some patients, is often at the substantial cost to quality of life in the way of cognitive impairment, and the drugs themselves can add to some of the comorbidities of epilepsy and produce depression and cognitive impairment. And I think importantly, with the ever-increasing cost of pharmaceuticals, millions of patients actually lack access to the drugs. So we have these drugs that may offer something new to a patient, and yet either their insurance or they don't have insurance, and so they're not provided access to it. And there are a lot of patients in developing countries who don't have insurance, and they're lucky if they can actually get phenytoin and phenobarbital available to them, much less some of the newer drugs that have come on the market since 1993. Melissa will talk in a few minutes about disease modification, and as you know, this is an area of active research in the epilepsy field, and the desire to find therapies that actually may halt or slow the progression of epilepsy in the susceptible patient population. That is an active interest of ours as well, in trying to utilize some of the chronic models that we have and are developing to try and identify drugs that may work in that particular patient situation. So one question that comes up is, does non-adherence to a therapy or the prescribed drug actually lead to therapy resistance? And is this something that we can model at a preclinical level? And I'm going to spend the next few minutes talking about the work of Cameron Hill and trying to do exactly that, is model it in a model or an animal model of temporal lobe epilepsy. So, as C. Edward Koop said a number of years ago, drugs only work if patients take them. So if adherence is poor and you have breakthrough seizures, then that can lead to a number of different things, either the risk of injury or status or SUDEP, But also, from a therapeutic perspective, it can also lead to an increase in dosage or a change in dosage form or drug form. So all of these can be the consequences of poor adherence, and poor adherence, like any disease state, is pretty prevalent in epilepsy as well. So it's been estimated to be as high as 59%. And as noted there, it's associated with seizures and SUDEP and injury, and again, an increase in cost to the patient and society. So Tracy Glauser and Avani Modi at Cincinnati Children's Hospital actually got us thinking about how to pre-model this at a preclinical level, and in particular to try and find a way that we could deliver drugs chronically to animals with epilepsy that mimic patterns that are seen in children with epilepsy. So shown here in this slide is 5 different non-adherence patterns. This is the overall summary of those patterns. You have near perfect adherence, the ideal patient, mild non-adherence, moderate non-adherence, severe delayed non-adherence, and severe early non-adherence. And what I find interesting about this slide in particular is not that it occurs in epilepsy as it does in other very severe disease states, but these are patients whose drugs are being administered to them by their parents. And so you would think that there might be actually a little bit more control and effort in the part of the parents to make sure that the drugs are being delivered as prescribed. But clearly that doesn't happen. This has been repeated by Glauser and Modi a couple of times now. And importantly, one of the recent studies would suggest that pediatric non-adherence can be related to lower long-term seizure freedom. So in a prospective study, they looked at 124 children ages 2 to 12 with newly diagnosed epilepsy. And children who exhibited early non-adherence of any form, whether it was mild or moderate non-adherence or severe non-adherence, were less likely to show seizure freedom of 1 year or more at their 4-year follow-up, as compared to children who practiced nearly perfect adherence had a much greater chance of being seizure-free for 1 year or longer at the 4-year follow-up visit. So you can see here 12% of patients in the near perfect adherence group were continuing to benefit from seizure freedom compared to 31% of those in the non-adherent group. It's interesting that that 31% in the non-adherent group is about the same as the percent of the patient population that is considered refractory across all different seizure types. So is the refractoriness that is reported, is that due to neurochemical, neurobiological, network phenomena and lack of an understanding of the biology, or does imperfect adherence actually contribute to that as well? So what I'd like to do now is turn actually to this animal model in which this is Cameron Hill. He received his PharmD 2 years ago from the University of Utah. And Cameron is very interested in translational questions. He came and got involved in this project right about the time that we had defined a process for delivering drugs. And his research question is really to ask whether improvement in adherence, non-adherence, or alone has a greater impact on seizure control than alterations in medication therapy. And I'll show you the experimental design in a moment. And his preclinical approach is to use chronic oral delivery of a drug to rats with epilepsy using a automated feeder system. So what we need to have then is a model of epilepsy that we can do continuous 24/7 video EEG monitoring with, and we need a mechanism to deliver the drug. And he had a couple of hypotheses that he was testing. Does anti-seizure drug dose escalation without a change in adherence patterns result in worse seizure control? And test the hypothesis that improvement in medication non-adherence without a change in dose results in better seizure control. So rats are not going to self-administer, and it's not because they can't get the safety cap off that bottle. It's just that their little paws can't actually get down there to grab the pill. So anyways, I had a biomedical engineer student, Kyle Thompson, a number of years ago, who actually designed an automated feeder system in which we could put drug formulate drug into pellets. Let's see. You can see the little round pellets here, formulate drug into pellets. And we could put them into this machine. Let's see. This seems to be.
As you activate the valves, it'll come up with a pointer.
There we go. So we've got drug in these pellets. We can put them in these bubblegum type machines. We can control that bubblegum machine with at any schedule that we want, every 4 hours, every 6 hours. Kyle designed an infrared sensor across this tube right here that counts the pellets. So we basically input the weight of the animal and tell it the dose, and it will deliver the dose at whatever schedule we want it delivered. So this is an example, if you will, of the feeder system. Let's see. And the video, I can't see. Link to. There we go. Thank you. So if you watch, the sound is. There's the pellets starting to drop into the cage here, and then this rat is actually. See the pellets in there. That was my colleague from Utah, Karen Wilcox. So next time you see her, you can tell her she's on video. What's interesting about this is we'll have a rack of 24 rats. We have two rats per cage block, so we'll have 12 cage blocks in a room. And if you don't believe in Pavlov's law, it's when the feeders start to go up in the upper left corner, and the rats in the lower right corner hear it, they're standing there waiting. They know the food is coming. That actually helps, if you will, for them to take the food. And they will eat most of the pellets at the time they're delivered, because rats don't always eat throughout the day. And they're a little bit food deprived, so they're hungry. But also the training, knowing that the food is coming, they will typically eat most of the meals at the time it's delivered. So here is the experimental design. We implant rats, spring dolly rats. We give them a week with an electrode, a head cap assembly to measure their EEG. Give them a week to recover. Then we induce status epilepticus with canic acid, systemic administration of canic acid. We then begin to monitor them, video EEG 24/7. At that same time, they get enrolled onto a low-dose, non-inherent dose and schedule of carbamazepine. So they're getting carbamazepine, 300 milligrams per kilo, 4 times a day, in a non-adherent schedule. So 50%, and the adherence is 50%. And the computer determines what the dosing schedule will be, and that's randomized every Sunday. And so that they don't get the same schedule every day, every day of the week. At the time that their first convulsive seizure, after 4 weeks of baseline recording, there's a therapy change, and they were randomized into one of 3 arms. One arm, the first arm, is where there is no change in therapy. They continue to receive 300 milligrams per day in a non-adherence schedule. Or they're randomized to another group where the dose is actually increased, 600 milligrams per kilo, and again, the non-adherent schedule. So nothing's changed about how they're getting it. The dose is just increased. In the third group, the animals actually maintain the same dose, 300 milligrams per kilo, but adherence is addressed. And so this is an example of some of the data that we would see. It's a little bit busy here, but what you can see on this line is the dosing schedule. The red circles here is when they receive a medicated meal. The black circles is a non-medicated meal. Either the blue diamonds above this feeding line represents a convulsive seizure, and the reds or the blue circles represents a non-convulsive seizure. And every morning we review the video EEG, a member blinded to the treatment. And this is the baseline period, this first 4 weeks, and this is the experimental phase. And this is an example of 6 animals that were on the same dose, non-adherent schedule. This is what the data looks like. The raw data looks like if you increase the dose of carbamazepine, you double the dose, but you maintain the adherence the same. You see a lot of clustering going on here. Animals are just having a big series of convulsive seizures. And this is 4 animals in which the adherence was addressed, but the dose stayed the same. And it's hard to see here. I'll show you the quantitative data in a minute about what happens. And unfortunately, we lost a couple of animals in this particular cohort due to telemetry failure. And so we only have 4 at the moment. We now have a number of animals that are enrolling into the second group, and the goal is to increase the N to 10 animals per group. So this is the quantitative data, and what you can see here is that if adherence is not addressed and the dose stays the same, and everything is normalized to their baseline 4-week period, there's about a doubling of the seizure frequency or the seizure burden. And so what that tells you is what we know is that the epilepsy in these animals is progressive. The seizure burden gets worse with time. And if you don't address the adherence but increase the dose of carbamazepine, there's no improvement in seizure burden, and there's no worsening. We don't have the statistics or the N to actually run the statistics. But what is interesting, if you keep the dose the same but you address the adherence, the baseline seizure burden stays the same. So if you look at convulsive seizures per day, again normalized to, this is actual seizure frequency, normalized to their baseline. Again, the control animals where the dose is not modified, and you see the baseline of about 200%. Where you double the dose, no improvement. If you address adherence, keeping the dose the same, it appears that maybe there's an improvement. The other factor that we're looking, an outcome measure that we're looking to, is the time to treatment failure. And treatment failure in this case is defined as a doubling of their seizure frequency. And again, we have a low end here, and this is very pilot data. But what's implied is that in this group where adherence is addressed, is the animals stay in the study longer, and compared to either the control group or the non-adherent double dose group. So in summary, our preliminary findings would suggest that addressing non-adherence patterns may have a greater impact than dose adjustment. And our ongoing studies are really aimed at increasing the N in these studies, and also beginning to evaluate other classes of anti-seizure drugs. Carbamazepine, as you know, is a voltage-gated sodium channel blocker. It would be very interesting to do the same with some of the other mechanistically novel drugs. And also, carbamazepine in rodents has a very short half-life, so we'd like to use a drug that has a longer half-life and see whether the pharmacokinetics makes a difference in these studies. And ultimately, the goal is to do PK/PD studies in which we're correlating efficacy to the pharmacokinetics of the drug. So what I hope I've been able to share with you is this is a novel way to deliver drugs in a chronic way. Most of the drug discovery models use acute dosing, acute models. This is a chronic model, chronic dosing. And we can also begin to think about add-on studies and crossover studies in these animals that are resistant to carbamazepine, in which we can really try to model a clinically relevant treatment protocol. And if you begin to think about treating also at the time of status epilepticus, where we can use this model to do long-term studies to identify disease-modifying drugs or anti-epileptogenic drugs. So at this point, I'd like to turn over the podium to Melissa, who is going to talk a little bit about disease modification and anti-epileptogenesis. And I was delighted when I was able to entice Melissa to move up to Seattle with me. Prior to that, she was Associate Director of the Anticonvulsant Drug Development Program, where she had been for 3.5 years. She received her PhD from the University of Utah, working with Kristen Keefe, looking at the impact of methamphetamine on early gene expression. And it's a delight. Melissa has gotten the lab up and running and here, and we're starting to do pharmacological studies in these and other models. And so she's going to tell you a little bit about some of the work with a virus, another model. Melissa, thank you.
Thanks, Steve. Thank you, John and Chris, for the opportunity to speak to you guys today. I'm going to talk a little bit about one of our newer models of epilepsy that we brought here to the University of Washington. I'm trying to find a good place for this microphone. Maybe I'll just use the hand mic. So Steve. Hello. 2 seconds. Steve talked a lot about trying to address the symptomatic seizures associated with epilepsy, as well as the latent period in which we've had an inciting event and animals or patients are at risk for developing epilepsy. But epilepsy is characterized by more than just seizures themselves. And so one of the questions that we're trying to address in utilizing some of these etiologically relevant animal models is, are there biomarkers of the disease course that we can use as surrogates of the epileptogenic process, and can we use those to as readouts for compounds or treatments or approaches that might mitigate the seizures or delay the onset of disease itself? And so one of the newer models that we're really particularly interested in is an infection-induced epilepsy model. And you might say, well, infection isn't typically synonymous with epilepsy, but I would beg to differ with you in the sense that inflammation itself is highly relevant in the context of epilepsy. There is quite a bit of evidence to indicate that seizure induction and maintenance is precipitated by inflammatory processes. There are a number of pro-inflammatory cytokines that are detected in human patients with epilepsy, and we can replicate that in our preclinical models of the disorder itself. One of the interesting things about epilepsy and viral and bacterial infections of the CNS is that it actually is a somewhat under-recognized long-term complication of those infections. patients who might have an encephalitic event are at higher risk for developing epilepsy. And there's particularly a greater prevalence of infection in developing countries. In the US and developed nations, reports indicate that infection accounts for only about 3% of all cases of epilepsy. But if you look at a country like Ecuador, that number has been reported to be about 14.8%. So it actually represents about a 5-fold increase in the risk factor for developing epilepsy in developing nations. Furthermore, if you have a seizure during an encephalitis event, your risk for developing epilepsy actually increases 22%. And the seizures that are associated with viral encephalitis-induced epilepsy are typically pharmacoresistant. And so we're trying to use this model as a way to identify new therapies for the treatment of acute seizures associated with epilepsy, but also to identify therapies that might modify the disease course or even prevent it altogether. And so to do that, we utilize the Tyler's murine encephalomyelitis virus model of infection in a C57 Black 6 mouse. This virus has been around for over 40 years as a model of demyelinating disorder or multiple sclerosis in preclinical models. But we found several years ago that if you infect C57 Black 6J mice, they actually present with an acute seizure phenotype, chronic spontaneous seizures, and many of the behavioral comorbidities of epilepsy. And so that's indicated by the fact that they do show these acute symptomatic seizures that present within days 0 to 8 post-infection, or DPI. The animals present with increased cytokine expression, specifically IL-6 and TNF-alpha. They demonstrate long-term reductions in seizure threshold. There's a significant hippocampal pathology and neuronal death exclusively within the hippocampus. There's a strong neuronal hyperexcitability that's consistent with temporal lobe epilepsy. The animals also, the acute seizures are also resistant to intervention with anticonvulsant doses of valproic acid, levetiracetam, and carbamazepine. And the spontaneous seizures do actually present in mice that were infected weeks after the viral infection period had cleared. And these spontaneous seizures are also associated with cognitive deficits and behavioral impairments during that spontaneous seizure time. It also shows increased anxiety-like behavior at this time period as well. And so I'm going to show you a video of a cage of mice that have been infected with the Tyler's virus. And for your information, all the animals in this cage have been infected with the virus. But you can see that 2 are actually already in the process of having a handling-induced seizure. And the way we do the handling-induced seizures is we'll just take the cage out of the rack over here in the animal facility, agitate it briefly, and the animals will start seizing. And you can see that it's a pretty substantial generalized, and it's upside down. So if you can just invert your eyes a little bit, you can see the animals are presenting with seizures, and this animal actually went through the full stages, all 5 stages of the racine stage seizure. I'm sorry that this is upside down. It got lost in translation. But we scored these seizures according to the racine scale, which is a graded scale, 1 through 5, 1 being the least severe limbic seizure, and 5 being the most severe, what you're seeing here, where the animal loses full body control. And if we look at the presentation of the acute seizure, handling-induced seizures during this 7-day viral infection period, you can see that when mice are infected with the Tyler's virus, 1 week, for the first week, they do, for the majority, show these seizures. But by 2 weeks, the seizures have subsided. If you then look at the number of seizures that animals are experiencing during the acute infection period, you can see that it presents as an inverted U curve where the animals show high levels of seizures around day 4, 5, and 6, and then the seizures wane, and by day 8, there are no more seizures that are presented. Furthermore, the severity of the seizures shows that same progression, that early in the infection you get stage 2 and 3 seizures, so mild seizures, as well as stage 4 and 5 seizures that are more severe. And then by day 4, 5, and 6, the severity of those seizures is significantly increased, and it starts to reduce with time. Furthermore, the duration of the seizures that the animals are experiencing shows that inverted U as well. So it allows us a really nice way to look at an evoked seizure period after a neurological insult. And so it gives us a model that has clear biomarkers of the disease progression, and it also offers us the potential to evaluate acute symptomatic seizure treatments, as well as compounds that may be disease modifying. So I'm going to show you how we're doing drug evaluation studies in the TMEV model. And as I mentioned, it offers us 2 ways to do drug evaluation. The first is using this acute anticonvulsant efficacy testing. So we can administer treatment during the acute infection period and look for the presence or absence of those acute behavioral seizures that we saw the upside down video of. You can administer therapies during any portion of this period according to the pharmacokinetics of the compound, and you can look for seizures before drug administration on each testing day or after drug administration, so you can see effects of the drug or absence of the drug. But we are also interested in looking at disease modification and how acute intervention during the infection period might modify long-term disease trajectories using behavioral comorbidity testing as our biomarkers. And so in disease modification studies, we can infect the animals on day 0, administer treatment at any point during the acute infection period or even after the acute infection period has subsided, and then look at behavioral outcomes, including seizure threshold and even neuroinflammatory processes. So I'm not going to go into detail about some of the acute anticonvulsant testing that we did, but suffice it to say, we've looked at the effects of anticonvulsant doses of valproic acid, carbamazepine, and levetiracetam, none of which showed acute improvements in the long-term markers of epilepsy. So they didn't improve any of the behavioral biomarkers that we're looking at. And so the question then becomes, are there other mechanisms of action that we can interrogate to try and alter the risk for developing epilepsy in the first place? Some of the areas of interest include anti-inflammatory therapies or compounds that might have epigenetic modification potential, because the majority of the anticonvulsant drugs on the market primarily interrogate ion channels. We're more interested in, are there other ways that we can modify the disease susceptibility?
Melissa, did those drugs stop the seizures during the acute phase of infection?
The valproic acid did. Carbamazepine actually made the disease worse. More animals had seizures. It's probably due to the fact that carbamazepine is associated with a state of hypoimmunoglobulinemia, and we didn't know that at the time, but the animals got significantly worse in this study. So to use our anti-inflammatory treatment approach for disease modification, we set out to use 2 compounds that have reported anti-inflammatory properties. The first is the repurposed antibiotic minocycline, which I was talking to somebody at AES a couple weeks ago, and they said it's a wonder drug. Cures every neurological disease. But it's reported to have the ability to inhibit microglial activation through IL-1 beta and TNF-alpha. And we gave this compound at a single dose once per day and looked at the acute seizure presentation as well as the long-term comorbidity markers. We also administered subtherapeutic doses of valproic acid because of its reported HDAC inhibition properties. Again, the dose of valproic acid was well below that which is necessary to inhibit a maximal electroshock-induced seizure. And so we weren't relying on the effect of valproic acid to block the seizure presentation. But what we found was kind of interesting, and there's a lot of data up here, but I'm going to walk you through it. The first thing that we always look at is just general changes in body weight. How do the animals, how are they how are they feeling after an infection? And you can see that in black, where's my pointer? You can see in black here that the vehicle treatment group shows a pretty consistent drop in body weight during the infection period. Interestingly, valproic acid significantly increased the body weight loss, or reduced the body weight loss associated with Tyler's virus infection, whereas minocycline treatment actually causes significant reduction or increase in the body weight loss. We also like to look at the latency to first seizure using Kaplan-Meier survival curves, and you can see that in the vehicle treatment group, we see a pretty consistent drop in the number of mice that are seizure-free. But minocycline, which is here in pink at the bottom, didn't significantly improve the latency to first seizure, so it was not really any different from the vehicle-treated group. Whereas valproic acid at sub-anticonvulsant doses did significantly improve the percent of total of mice that were seizure-free. Furthermore, the cumulative seizure burden was blunted with valproic acid treatment in yellow, and minocycline didn't have as robust of an effect on the cumulative seizure burden. And seizure burden is a sum of the racine stages of seizures for each day. So if you had a mouse on observation day that had a stage 5 and another mouse that had a stage 4, your seizure burden for that day would be 9. And so we take the cumulative seizure burden for all the observation periods and look at the trajectory of the disease. And the overall seizure burden, looking at AM and afternoon dosing schedules, was not too different between the two treatment groups. But what was more surprising to us was the fact that mice treated with valproic acid, there were significantly fewer of them with seizures, whereas minocycline did not significantly alter the proportion of mice that presented with seizures. So minocycline didn't actually modify the acute insult itself, whereas valproic acid did seem to have a pretty robust effect. But when we then wanted to look at the long-term outcomes of these animals after this anti-inflammatory approach. And so one of the behavioral outcomes that we look at for drug screening purposes is this open field exploration task, which you place a mouse or a rat in the center of an open field, and because they're prey species, they want to spend the majority of their time around the perimeter of that chamber. If an animal spends a lot of time in the center, you might consider them to be less anxious because they're not as worried about going into an exposed area. And so high center exploration is consistent with a reduced anxiety-like behavioral phenotype. And so when we looked 6 weeks after this infection period, we first looked at the time that the animals spent in the center of the open field, as well as the activity, or the amount of activity that the animals spent in the center of the open field. And what we were surprised to find was that despite the fact that minocycline didn't really have any robust effects on the acute seizure period, it did show a significant increase in the time that the animals spent in the center of the open field, as well as the amount of activity that they spent in the center of the open field. Furthermore, when we looked at total distance traveled in this open field, so this is the entire distance within the traveling within the open field, we can use that as a measure of spatial memory. So if a mouse went over to this corner and explored, and then 2 minutes later goes into this corner and then goes back to this corner, then it might indicate that they don't remember that they were just there, so they might go back and forth between the chamber more frequently. And what we found was that minocycline, again, reduced the total distance traveled relative to animals that were infected with TMEV and treated with vehicle, suggested that they had an improved spatial memory relative to their vehicle-treated controls. What was also interesting to look at was the changes in seizure threshold at this long-term time period. And so using a intravenous infusion of the chemoconvulsant metrazole, we can look at the latency that an animal will have to their first twitch, and then look at the latency that the animal will have to clonus. And when we looked at, we included a sham-treated cohort in this group because we had never done testing with C57 Black 6 in this task, and they were age matched. When we looked at the minocycline-treated group, we saw a significant increase in the amount of metrazole necessary to elicit twitch, as well as an increase in the amount of metrazole necessary to elicit clonus. But we did not see that same increase in seizure threshold with valproic acid-treated mice. But if we also look at other measures that are not our standard outcome measures in this seizure threshold test, we were actually a little bit more convinced that minocycline had a really robust disease-modifying effect. And those measures included the percentage of mice with tonic extension seizure, which would be akin to a generalized seizure. And we found that in the sham group, the majority of mice did not have tonic extension seizure. But mice treated with vehicle and infected with TMAV showed a significant increase in the proportion with tonic extension seizure, and valproic acid was actually no different from the mice that were infected with treated with vehicle. But surprisingly, minocycline was no different from the sham-infected cohort, so they did not have a significant reduction in their tonic extension seizure threshold. And moreover, the proportion of mice that survived the IV metrazole infusion, in the sham-treated group, the majority of mice do actually survive. In the vehicle-treated group, none of the animals survived. And when we looked at the minocycline-treated animals, they were more like sham as well, further supporting the fact that minocycline did indeed have a disease-modifying effect in this study. So what I hope I've convinced you of today is that in the context of this viral infection model, acute seizure control itself is not necessarily sufficient to improve long-term behavioral outcomes. This is supported by the fact that valproic acid-treated mice did not explore the open field any differently than vehicle-treated animals. They were no different from vehicle-treated TMDV-infected mice. The seizure threshold of the valproic acid-treated mice was actually not different from the vehicle-treated mice infected with TMAV. However, minocycline-treated mice, which did not show notable improvements in their acute seizure endpoints during the viral infection period, did show normalized open field behavior, and they did show normalized seizure threshold 6 weeks after the viral infection, at a time when we know that spontaneous seizures are presenting. And so I think the take-home message is that the TMEV model itself allows us the opportunity to potentially identify novel therapies that may otherwise be missed in standard screening approaches. And so I think altogether, in combination with Steve's talk today too, we can all agree that appropriately powered clinical trials for anti-epileptogenesis are really difficult to do in the clinical arena. And furthermore, they might be a little bit unethical and costly. But the problem is that less than 5% of the drugs that are entering our preclinical testing arena ever reach FDA approval. And so for us, as translational researchers, the challenge is to try and develop better models and approaches. We can introduce therapy once symptoms have presented, but the bigger question and challenge to have a meaningful impact for patients is to identify therapies that we can administer in at-risk patient populations after an insult, but before the symptoms of the disease have occurred. So I hope that you can appreciate that the Tyler's virus model is indeed an etiologically relevant model that might allow us to identify better therapies for temporal lobe epilepsy. And this is because it allows us a really great ability to intervene at specific time points in the disease process. We can model clinical trial designs in our preclinical studies. This particular model has a natural progression to temporal lobe epilepsy, and it has clear clinical similarities. It also presents with a number of biomarkers that allow us to utilize it for preclinical drug testing in a moderate throughput approach. And with that, I will thank a lot of people on behalf of Steve and myself.
I think we could tag team on questions and answers as well.
No, I guess I'll start. Thank you both. That's really interesting, both of you. I guess, Melissa, 2 questions on your model here. So has minocycline been looked at non-TMEV models of epilepsy for long-term effects?
Non-TMEV, yes. So the question was, has minocycline been evaluated in other models of epilepsy? So there's a group that, her name is Suki Koch at Northwestern, she's at Emory. They looked at the 2-hit model of epilepsy where they introduced an insult, and then they were able to use minocycline to prevent the epileptogenesis process in that model. And it was effective.
Yeah, no, I just wonder about that because I think it's a viral model and you might be specifically activating immune cells and maybe something very specific about that.
Yeah. And so I didn't include in this talk, but we actually did 2 doses of minocycline and we did twice daily administration. The high dose of minocycline actually made the disease worse. We had to euthanize the mice. They were not happy.
And then the other question I had was, since minocycline has a lot of off-target effects, other than just sort of modulating microglia, we don't really know exactly what it does. Have you thought about other ways to modulate microglia in the TMEV model and see if that mimics your own?
Yeah. The question was, have we thought about other approaches to modify the microglial activation without using minocycline? And the answer is yes. We're working on it. It's definitely something that we're interested in and would like to pursue.
A question about the dose of carbamazepine that you were talking about, Steve. It's 20 to 30 times higher than what we would use in a child. And you mentioned that the half-life is short in the mouse. It's short in the human also. And so I was just curious if the dose that you're using is based on the metabolism or if the canic acid model just requires that much carbamazepine to control.
So the question is related to the dose of carbamazepine that was used in the automated feeder systems and the half-life of carbamazepine. And indeed, Dr. Grasby, you're correct. I mean, it's a high dose even for rodents, because if you look at the dose that'll block a maximal electroshock seizure in these same rats, it's about 30 milligrams per kilo orally, which is 1/2 to 1/3 of this dose. These are 300 milligrams per kilo QID, so they're getting 75 milligrams with every beating. So the other aspect of this that we're finding with this model is it is highly pharmacoresistant. So carbamazepine has been shown in other sort of chronic models to be effective, when it is effective, at somewhere around 50 to 100 milligrams per kilo. So, and that's one aspect of this particular model that we're also interested in, is if it's that pharmacoresistant to carbamazepine, we can identify those animals very quickly and then cross them over to an investigational drug or to another drug to see whether we have a higher efficacy. But ongoing studies really are aimed at doing the pharmacokinetics and the PK/PD modeling in these animals, so we can actually correlate whether the blood levels that we're actually achieving with this dose of carbamazepine are therapeutically relevant. And the first go at that suggests with chronic administration we get about 10 micrograms per mil of carbamazepine, which is pretty close to a therapeutic level. Yes?
Maybe along those lines, do you know what your model is showing is that the microglia cells are involved, and if you block that, what actually drives the seizure? Is it an increase in glutamatergic transmission, a decrease in GABA, a change in astrocytic glutamate uptake? Because that might also help you think about what is it going to be resistant to or not.
So with regard to this particular model, I think all of the above are probably the question was what is driving the seizure and with regard to the post-status epilepticus model. I'll let Melissa address the TMEB model, but in the particular the post-status epilepticus model, there's certainly an increase in inflammatory markers. So we have some of the same markers that Melissa talked about in the TMEB model. There's an increase in glutamatergic tone and a reduction in GABAergic tone. Post-status, there's a loss of inhibitory interneurons in this model and a significant loss in the hilar region of the hippocampus. So there's a marked imbalance between excitation and inhibition here. But you're absolutely right. I think one of the things that we have to do in all of these models, because the standard approach using standard anti-seizure drugs targeting ion channels does not work. And so we have to look beyond the cell membrane intracellularly to second messenger pathways, and that's working with folks here like yourself and others. We're really excited about that opportunity to kind of interrogate those second messenger pathways. Melissa, do you want to?
In regards to the Tyler's virus model and other infection-induced epilepsies, I think there's still, at least for this particular model, there's still a lot that we don't know about what actually is causing the seizures. But in the context of clinical encephalitis, you would probably hypothesize that the neuroinflammation that's going on and the neurodegeneration that might be occurring is going to cause a lot of network rewiring that might contribute to an imbalance in the glutamate and GABA drive. We know in the Tyler's virus model specifically that animals have neurodegeneration as early as 4 days after the infection, and we see astrocyte reactivity and microglial reactivity at that time point too. We haven't looked at microglial expression much after about 14 days, but we can still see some reactive astrocytes long after at the time point when we're looking at the comorbidities, 4 to 6 weeks later.
So interesting stuff, Steve and I and Melissa. I would certainly say that the work that you described, Steve, sounds to me really important. If in fact non-adherence winds up making epilepsy worse, that's something that patient populations would really pick up on and be responsive to. Up to this point, it's just if you don't take your medicine, you may have a seizure, end of story. But to tell them that your epilepsy may get worse, that's a whole other issue altogether. Do you have a theory for why that is so? Why is this non-adherence producing more epileptic seizures?
The question is, why does non-adherence result in more epileptic seizures? So it's an interesting phenomenon. I think one of the things that is emergence, we're always looking for the generalized seizures, the tonic-clonic seizures, the ones that have the convulsive seizures, if you will. I think in patients as well as in these animals, we're seeing a lot of non-convulsive seizure activity that's going on sort of in the background. It's not necessarily affecting the animals and perhaps even the patient to any great extent. But the question that's emerging is what is the impact of those non-convulsive seizures on network reorganization that's leading to sort of this latent hyperexcitability, so that if there are other environmental factors or behavioral factors that's causing an acute lowering of seizure threshold, lack of sleep, stress, alcohol, or drugs per se, then that, if it lowers your seizure threshold just enough so that you actually can have a seizure. The other factor, in particularly the animals, as you saw, one of the things we're starting to analyze now is the cluster frequency. And these animals are having large clusters, groups of seizures in clusters that are coming more and more frequently with the progression. And those convulsive seizures are likely producing more inflammatory response, perhaps more damage. We don't know. We haven't actually looked specifically at that. And that actually can cause, again, a further network reorganization and increase the hyperexcitability. So one thing that we'll have published here pretty quickly, I hope, is what is the impact of missing a dose in a meal, and how many meals out, if you miss, will you have a seizure? So in a pilot study leading up to this, there's a correlation actually. If you miss a dose 6 meals previously, there's a correlation to a subsequent seizure. So you're looking actually at a day and a half or about 5-6 half-lives of carbamazepine. So as you can well imagine, no, doctor, I took my drug this morning, I took it last night, and I took it yesterday morning. But the patient may not remember that they missed the dose 2 days ago. And so is that, despite everything else that they've been doing, taking good, the last 4 doses, but they missed one that set them up for some sort of local hyperexcitability, and then all of a sudden the planets align, seizure threshold drops, and they have a seizure. I don't know, Bruce.
I think that was your answer. You don't know, right?
That's a long way.
Yeah, I mean, because it does make some sense to me that there could be some plasticity in these hyperexcitable circuits. And if you let this plasticity exercise during a period of time when there is not good seizure control, the plasticity is more robust. Yeah. So you just have more subsequent seizures. You're going to need something testable to dig into this at the next level. And it just struck me that could be a hypothesis. And Melissa, I need to know from you whether or not you've given minocycline to animals that have some sort of a fixed seizure disorder. In other words, might you be able to implicate, microglia in seizures generally? Forget about this infectious state, but just something that manipulates the biology of microglia.
No.
Are you going to do that?
That would be great. It's just a matter of time. This work we just completed this work, and so now we're asking a lot of questions about what can we do next with minocycline in other models that we have. We have a lot.
I think it is also interesting to mention that minocycline in the acute seizure models has no effect, as you might expect. So, but its effect we tested in the corneal kindling. I can't recall.
We did test it in the corneal kindled mouse, and it did work. But yeah, we haven't published that.
So why minocycline? I know other people like Ray Beagledine had a story with NSAIDs reducing development of chronic epilepsy if given during status, and I think a group at Cleveland Clinic had a study showing that splenectomized animals didn't develop epilepsy as robustly following status. Are you guys looking at other NSAIDs? You hinted maybe there's a mystery drug you're looking at, but do you use ibuprofen, for instance? Does that make a difference?
Yeah. The question was, why did we choose minocycline? And the short answer is because that was the hot new anti-inflammatory drug on the market when we started this, not the market, but in the preclinical arena when we started this project several years ago. But I think it's certainly highlighted the need that we need to look at a lot of other anti-inflammatory compounds because you guys bring up a number of issues. Minocycline does have a lot of antibiotic or antibacterial effects. Would it also be dampening the immune system in general that might attenuate the disease course? So we have a lot of plans for this work, and we just need more time.
I mean, to your point about Ray's work with the COX-2 inhibitors, I mean, that would be an ideal sort of molecule to put into this. And and it's something that we're going to pursue probably is down those particular lines. Minocycline, I think, was also a drug of convenience from the perspective of it's a repurposed drug, and there's a lot of safety and data on it in the human population. So, if you had evidence supporting something like this, it perhaps could make its way into a clinical trial pretty quickly. But then that becomes, the next question is, what's the clinical trial and what's the patient population and how is that designed?
And I will say that I don't think I would advocate for minocycline to go into the patient populations based off of the ALS trial data with minocycline that actually worsened the disease course for those patients. And as I mentioned, when we gave a higher dose of minocycline, it actually caused the acute seizure period or seizure phenotype to be worsened, and the mice lost so much weight that we euthanized them. But the challenge is now, can we look at some other anti-inflammatory drugs, and that's a definite yes.
Thank you. Thanks, guys.
Thanks.